on all the phones. They are all been on mute, but we do want to hear from you. So during the presentation, if you have questions for the presenter, we do ask that you submit those via the chat box. And at the end of the presentation this afternoon, we will get through as many questions as we can. Also, as a reminder, this event is approved for 1 CEU. So at the end of the presentation, when we close it out, please stay on your computers and a post survey will appear, giving you the opportunity to share your feedback. After hitting the submit button, another screen will appear and will link you to the CEUs. So that's a good opportunity for everybody. Next slide. So what's this call about? It's Dr. Butler is joining us today. She's from the University of Washington. I'll give a little bit more introduction in just a minute. She's going to be talking about opportunities to improve the kidney transplant evaluation process. And as I mentioned just a minute ago, we will have some time at the end for some questions and answers. So please submit those through the chat or Q&A panels during the presentation today. So with that, I'll go ahead and introduce our speaker. Dr. Butler is an acting instructor in the Division of Nephrology at the University of Washington and a Health Service Research Fellow at the Seattle VA. Her research interests include healthcare intensity at the end of life for older patients with advanced kidney disease, opportunities to support person-centered and centeredness and equity in the kidney transplant evaluation, and healthcare resource allocation during the COVID-19 pandemic. She received her BA degree from Tufts University, her MD degree from Washington University and St. Louis School of Medicine, and completed her internal medicine residency, nephrology fellowship, and master's degree in bioethics at the University of Washington. So we're really pleased to have Dr. Butler with us. Dr. Butler?
Thank you, Stephanie. I really appreciate the opportunity to present at this forum. And the objectives of this talk, as were briefly mentioned, to review ethical considerations in selecting patients to receive a kidney transplant, to explore care processes in the early steps of the kidney transplant evaluation, and then to identify opportunities to improve the kidney transplant evaluation and selection process. And I've split the talk into 3 sections, roughly tracking these objectives. So I think a good place to start is that kidney transplant can be great. Transplant's often the preferred option for people with advanced kidney disease. It can offer improved quality of life and longevity. And we know more and more that that's for a huge swath of people, people who are older, people who have multiple comorbidities. Many people can benefit from a kidney transplant. The problem, of course, is that there are far more people in need of a transplant than there are available donor kidneys, and not everyone has a willing and able kidney donor, living kidney donor. So just to put some numbers to this idea, there were about 500,000 people on dialysis in 2017, and only about 20,000 kidney transplants in that year. So this situation of limited availability makes donor kidneys a scarce healthcare resource, and there's special ethical considerations to think about in these kinds of situations. Usual clinical practice that we think about is mostly focused on the patient, on person-centered, patient-centered considerations, and population health discussion is usually kind of in a different realm. They're approached separately. But in the case of kidney transplant, patients' needs and population level considerations can conflict. So what do we do in these situations? Well, the first thing, of course, would be to fix the problem of scarcity. For transplant, that might mean decreasing the number of patients with kidney disease, the number who need kidney transplant. Of course, that's a priority for many reasons. And then the alternative would be to increase the number of donor organs. And there's a lot of energy invested in this goal, of course. So for example, we could try to improve organ procurement. We could reduce the number of good quality kidneys that are discarded. And we could encourage living donation and many other strategies. This is a huge topic and very important. I'm going to shift and focus on instead what we do in the situation that we are in of resource limitation. How do we allocate kidneys in this setting? So importantly, there's multiple ethical considerations guiding any approach to allocation of scarce healthcare resources, and these principles can sometimes conflict. So I'm going to use the United Network of Organ Sharings approach and think about 3 ethical goals in transplant allocation. The first goal is to promote the greatest good, to maximize the aggregate benefit that a given supply of resources can provide to the population. So for kidneys, that might mean saving the most life years or graft years. So maximizing or allocating kidneys in a way that promotes the greatest number of total years for the population. And I start on this ethical principle because the goal of providing good, of maximizing benefit, is very familiar to people in the healthcare community. Our jobs are to benefit patients. But there are a few particular things to keep in mind as we think about this principle as it applies to kidney transplant. When trying to optimize the greatest good, we have to first decide what that good is. What good are we trying to maximize? And we've learned the importance of considering this very carefully through a difficult history in nephrology. And I'm referring to back in the 1960s when dialysis machines were the scarce resource at that time. In Seattle, a citizen committee chose how to allocate those scarce resources and decided to allocate based on what they perceived to be each candidate's social value. So they chose people to receive a life-saving treatment based on what they thought they would contribute back to their community. And of course, looking back, this kind of approach is at best highly subjective and at worst overtly discriminatory. You might propose maybe a more nuanced approach to thinking about not just life years saved, but the quality of those years. So some have suggested an approach based on quality adjusted life years. And in that case, we might prioritize people who are maybe more physically functional, who are thought based on this criteria to contribute more quality adjusted life years. But again, I think it's important to be careful about this kind of approach because what constitutes a valuable or high quality year is itself subjective and may differ between patients. So that gets us to the next goal of an allocation system. We have interest in not just optimizing the total benefit, but distributing that benefit in a way that's equitable across the population. So ethically arbitrary factors like race and gender really shouldn't shape our allocation process. So for kidney transplant, we can't, of course, offer everyone similar treatment. Not everyone can get a kidney transplant. We can't subdivide kidneys and kind of spread them evenly over the population. But what this means for this situation is not that people get equal treatment, but that people get equal opportunity, equity and opportunity to receive a kidney transplant and similar access. And of course, health equity is an increasingly important consideration and more recognized. Over the last year, multiple national kidney professional societies and governmental authorities have made it clear that this is a priority for healthcare. And then the last consideration is person-centeredness. And supporting patient autonomy is, of course, a central tenet of U.S. healthcare and one that we'll all recognize as well. The important point here is that this goal applies even when patients' options are constrained by external considerations like resource limitation. So for regarding kidney transplant, we can support person-centeredness by giving patients the information that they need and helping them to make decisions that align with their own preferences and values within external constraints. So how have we operationalized these considerations in the process of allocating kidneys as we do today? Among patients on a national wait list, deceased donor kidneys that become available are allocated based on multiple principles or multiple rules, mostly based on wait time, then also with some considerations for factors like organ matching and how close patients are to the organ that's being donated. And over the decades, there's been interest in iteratively refining, improving this approach and the rules that we use to allocate. In 2014, we had a big shift that we now call the new kidney allocation system. And the goal in this shift was really to try and do better with optimizing benefit of a given donor or given pool of donor kidneys, and also improving equity in the process. So this involved multiple changes. One of the new rules instituted a strategy of longevity matching, and that means that patients with longest expected post-transplant survival are matched with kidneys expected to also last the longest. And the idea here is that patients who are likely to live longest won't outlive their kidneys and end up back on the national wait list. It's also been increasingly recognized that some groups of people have delayed access to care and therefore delayed access to kidney waitlist and to transplant. So the concern, of course, is that this kind of delay in access to care disproportionately impacts people of color, people who are socioeconomically disadvantaged. So to begin to address some of these disparities, the rules of the kidney allocation system were also changed to start with this waiting time clock from the point of dialysis initiation for those patients who were already on dialysis at the time that they were added to the wait list. And then finally, the waitlist selection process, the kidney allocation system, is published, openly available. There are publications that are easy to understand for patients and for providers. And there's also been, in coordination and separately, a proliferation of decision tools and patient-friendly information about treatment options for transplant versus dialysis to try to help patients decide between these options. I want to really stress that these improvements and others have been possible because of a robust process improvement infrastructure that involves monitoring, identification of problems, development of solutions that are agreeable to all stakeholders, and then systematic implementation of changes. So for our example, the new kidney allocation system was a major revision to the process in 2014. But before this new kidney allocation system, there were decades of research and modeling and public and kidney community discussion and deliberation about possible ways to improve the process. And then, of course, before that, we needed to identify the disparities in access and inefficiencies. And even before that, the very ability to identify problems is centered on having good information and transparent processes. So the waitlist allocation rules that we have currently are, again, publicly available. There's a national registry of patients on the waitlist and those that are transplanted that allows us to track patterns and be able to respond to them. So because of these series of steps, the cycle can continue, and we're able to monitor the results of the new kidney allocation system and identify ways to improve it going forward. The results of these system changes are still pending. We'll continue to get them over the next decade, but initially, for the first few years, we see a greater proportion of Black patients being transplanted off the wait list, and possibly some improvements in the rate of patients having to be relisted at 1 year. So I think the National Kidney Allocation System, although not perfect, is a great example of an allocation system that tries to incorporate multiple ethical principles and also has a mechanism for evolving with clinical advancements, with better understanding of public sentiment, and to really optimize individual patient needs. The National Kidney Allocation System, this process that we've been talking about, is only one part of an entire kidney evaluation and selection process. The entire process involves a series of steps for patients and their providers. So just briefly, patients establish with their kidney providers and discuss their interest in transplant. They might do some initial evaluation tests locally. They're then referred to a transplant center. They complete a physical and psychosocial evaluation, which might include tests, clinic visits, other treatments. And then the transplant center committee decides whether this patient is a candidate for kidney transplant. And if they are, they place the patient on the national kidney allocation or the national kidney wait list. Patients might also at that time start to look for a living donor. Patients can wait 3 to 7 years, but of course that varies before being selected under the national kidney allocation wait list, or sorry, the national kidney allocation rules that we just discussed. And then finally, they'll have a transplant. They'll undergo transplant surgery. The majority of the national focus on process improvement and study has been focused on these later steps in the transplant process. But I'd say that the outcome of the kidney allocation system can really only be as good as the input. So the selection process as a whole is really only as effective and fair as upstream selection processes. We know a lot less about earlier steps in the process, and that's in part because care processes related to these steps are often distributed across several independent institutions. There's not a systematic way of collecting information or standardized processes to describe these steps, unlike the national allocation from the wait list. We do have some studies, mostly single center or regional, and they show some signals of concern. I'll just give you a few examples. Dr. Patzer and her colleagues in Georgia reported that Black patients are less likely to be waitlisted within the first year of starting dialysis. Alexander, back in the 1990s, studied a group of patients who were all considered medically suitable and all interested in transplant, but nonetheless found that people with lower income were less likely to be waitlisted. And data coming out of Canada from Dr. Kim and his colleagues shows that, among other patterns, women seem to be less likely to be referred to a transplant center. People living farther away from transplant centers are also less likely to be referred. There's been some nice work hinting at how patients think about and experience this part of the transplant process. One survey study among a group of people on dialysis by Dr. Wachterman and her colleagues showed that about 66% of these people on dialysis thought that they were transplant candidates, but when their nephrologists were surveyed, they suspected only about 40% were candidates. So suggesting a disconnect in expectations about whether one can get a kidney transplant. And then another work by Dr. Gillespie, 90% of patients getting worked up for kidney transplant assumed or thought that they were already on the national wait list. So signaling some misunderstandings about how the process works and how close they were to getting a kidney. Some of our own qualitative work and qualitative work from others also suggests that the transplant evaluation can be quite overwhelming for patients and families. So for all these reasons, I think it's critical to understand the evaluation process upstream of the national waitlist. And as I've mentioned, the barrier here is that we're limited in what we can say about these steps because data is not systematically collected. The VA is a integrated national healthcare system that conducts all steps of the transplant evaluation and selection process from initial discussion all the way through transplant itself. And this gives us an opportunity through the VA-wide electronic medical record to track care processes happening within the VA system. So with this, I can give you a sense of some numbers. So there are about 13,000 veterans, people with new end-stage kidney disease annually in the VA system. About 1,300 of those are referred to a regional transplant center. 950 are accepted for on-site evaluation by that center. 600 of those are added to the wait list annually, and there are about 160 transplants within the VA system each year. So certainly the VA serves a unique population, and it's a unique system. It's an integrated national healthcare system. So certainly there are care processes that are going to be unique to it. And one I'll point out in particular is that much of the kidney transplant evaluation is done locally at the local VA center before referral to a transplant center. And a lot of this evaluation process is standardized through the VA national office. So these numbers are only going to approximate, but I think that it reinforces the point that much of the selection process is happening in earlier steps. So we see a large number of patients maybe dropping out at early steps in the evaluation process. So before transitioning to the next topic, just to review, we have discussed how kidney transplant allocation is guided by multiple ethical principles, how the focus with a goal to improve support of these principles is mostly focused on waitlist selection. And there's little known about upstream processes, but we do see some signals for concern. So the information I reviewed so far has, I hope, reinforced the importance of better understanding the kidney transplant evaluation process as a whole. And I'd like to share some of the work that my colleagues and I have done recently to this end in a little bit more detail. So just briefly, for a national group of 211 patients who were referred to a VA transplant center, we used the national VA-wide electronic medical record to track episodes of care related to transplant across clinic and hospital settings. And we extracted and used clinical notes as the data for a qualitative analysis. And this qualitative analysis resulted in 4 dominant themes. And I'm going to go through those themes and offer some example quotations from the electronic medical record to illustrate them. So the first theme describes what could be a far-reaching and sometimes inflexible medical evaluation for kidney transplant. Clinicians tend to approach the evaluation with a broad mandate to uncover any undiagnosed conditions and fully characterize existing diagnoses. So the associated battery of tests could uncover sometimes asymptomatic or mild conditions, and that could lead to a cascade of testing and treatment. The patient said, "I'm like an old car. They keep finding more things wrong with me and fixing them." The diagnostics and tests as part of the evaluation could sometimes be invasive, burdensome, even harmful. In pursuit of renal transplant, he underwent percutaneous liver biopsy, complicated by hemophilia and occult GI bleeding. Despite these kinds of risks and burdens, there also seemed to be little accommodation for patients' unique circumstances and preferences. They recommended CT-guided biopsy, but he initially refused this, as he personally feels it's unlikely that he has cancer and is willing to assume the risk. If he wants a kidney transplant, this issue needs to be resolved before that. The second theme describes a valuation of patient's psychosocial condition. So the psychosocial evaluation was a big part of the transplant evaluation, and it could really mean a deep dive into patients' personal history, including living arrangements, historic substance use, their finances. And so the recommendations incorporating these kinds of assessments could sometimes stray into patients' personal lives. The patient should consider nourishing his relationship with his wife, importance of a healthy relationship with his wife prior to and during the transplant process. Clinicians wrote letters of referral for patients to the transplant center, and they could, when they incorporated this kind of personal information, they could allude sometimes to patients' moral deservingness for transplant. Because of his youth, combat service, 2 tours in Iraq, and excellent functional status, this writer feels that the patient should be given the highest priority. A big part of the transplant requirements in the VA is to have a 24/7 caregiver for a period of time after transplant surgery. And some patients had family members who were really willing and able to go to lengths to fill this role. They quit jobs, they sometimes moved, all to support, to be able to support their loved one. But this was a substantial ask, and some patients didn't have family or community that was able to take on this role, and that could be prohibitive to transplant for these patients. His wife is disabled, so not able to accompany and help him. It's unlikely that he'll be able to find someone who can put their life on hold for a month without compensation. In the next theme, we describe intense surveillance over patients' behaviors in order to determine whether they were adherent to medical recommendations. How patients fared during the transplant evaluation could be viewed as a sort of test of how they were likely to behave after transplant. The entire transplant evaluation is somewhat of a litmus test to see if he can follow through appropriately with each step. There were also extensive efforts to monitor for signs of non-adherence or non-compliance, such as missed dialysis sessions or clinic no-shows. He misses too much dialysis and is well over a year in getting vascular access done to be a good transplant candidate. Compliance red flags. Non-adherence with medications was seen as especially concerning because of the need to stick to immunosuppressants after transplant. But we also saw examples when clinicians tracked behaviors that didn't seem so directly related to post-transplant care. Of note, when he arrived at this VA, after checking in, he went to a nearby casino without alerting the floor. He was cautioned about such behavior being perceived as non-compliant. Finally, patients and their local providers seem to have little insight into the evaluation and selection process and often little power to shape it. Patients, for their part, were highly motivated to do whatever was asked for them in the transplant process. Appears to be compliant, states that he would do anything to keep from keeping on dialysis. Then providers, to support their patient's candidacy, sometimes would do tests that they didn't otherwise see as indicated, or that they might not even see as best practice. There's good evidence that preoperative revascularization does not decrease the risk of perioperative ischemic events. We've become reluctant to perform catheterization solely for this reason, but criteria for listing the patient for renal transplant are different. The transplant centers often sent documentation, a documentation letter of their conclusion about whether a patient was a transplant candidate, and that was also reflected in the medical record. But it could be a little bit ambiguous about what factors they were using to determine candidacy. And notes that we saw quoting patients' response to these decisions captured how distressed they could sometimes be at what they perceived to be an arbitrary or unfair process. The patient said, "I don't understand. I've jumped through hoops and done everything they've asked." He described his hopeless outlook about getting a kidney transplant. Somewhere in Washington, D.C., some person behind a desk is going to be looking at my file and say, "Do we even want to give it to this guy?" So collectively, these findings identify some possible impacts on the multiple goals of our allocation system, and especially, I think, on considerations of equity and person-centeredness. In terms of equity and thinking about equity, what we saw were often somewhat subjective criteria, and in particular, criteria related to the psychosocial evaluation. And that could mean that similar people might be treated differently. Assessments of compliance might disfavor people with particular groups of people with limited resources or challenging living environments, for example. And these kinds of subjective assessments are also vulnerable to the impact of implicit biases. And we know that these disproportionately impact people of color, older adults, people with disabilities, and people who are socioeconomically disadvantaged. This work and others have also highlighted some of the major burdens and even harms that patients can take on during the transplant evaluation. And like many care processes that involve trade-offs for patients, that means that the decision to pursue transplant involves patients weighing risks and benefits. But despite this situation, patients, we found, could sometimes have very little insight into what the transplant process, what the evaluation process meant for them. Many patients were unsure of what to expect from the evaluation, and has been seen in other work, unsure of where they are in the process. In fact, I'd say that a sense of being monitored for compliance might even give patients the impression that they were expected to adhere to all kinds of medical recommendations, whether they're related to the transplant process or external to it. This kind of limited transparency that we've seen might have been perceived by patients to be arbitrary or suggested that process is unfair to them. And it likely also impacts trust in a system of allocation that is ultimately for a public resource. So to review the main results of this study, we saw that patients could engage in an extensive physical and psychosocial evaluation that could sometimes be highly subjective and over which neither they nor their local providers sometimes had much understanding or control. And these findings, I'd suggest, identify some barriers to equity and person-centeredness in the kidney transplant process. So with that in mind, what opportunities do we have to improve this process? And here I have just as many questions as suggestions, and I very much welcome any thoughts from the audience. But I think we might start by thinking about ways to address these concerns by using the same process improvement framework that supported the national kidney allocation system. So we and others have begun to fill in some of these gaps in understanding what the process is like and maybe some possible concerns, but much more research is needed. The information that we have currently is mostly regional, institutional, or like our work in the VA, relates to certain groups of patients. Stakeholder engagement is also really key to improving the process. And that's in part because ways that we intend to balance big principles like equity and maximizing benefit don't have one answer. The answer is really to involve multiple voices and come to consensus. One barrier to engaging stakeholders suggested by our work and others is that there may be a lack of communication and siloed responsibilities between clinical teams. So, of course, the transplant team is an integral part of the evaluation and selection process. But local kidney care clinicians and dialysis providers are right there with the patient. They're maybe in an optimal position to help their patients make decisions about dialysis and transplant that really align with their big picture goals. But to do that, these local providers need to be empowered to participate in the process and to know what to expect from it. Community involvement is also key, and not just the medical community, but the public community and people that are impacted by kidney disease. And as I began this this point with trade-offs between promoting greatest good and equity, for instance, are not self-evident. We need to a process of deciding in a way that many stakeholders agree to. And then finally, I think there's an opportunity to engage patients as active participants in the transplant evaluation process. As I've said before as well, there's certainly boundaries around care options, as there are for other kinds of medical care, but patients can still have the opportunity to participate in decision-making to the extent possible. One actionable step might be to expand our current repertoire of communication tools and decision aids beyond the decision about transplant versus dialysis to include a more nuanced discussion about the process that they would also be required to go through to get a transplant. I think there's also opportunities to improve our approach to the evaluation based on the information that we have. The Department of Health and Human Services regulates the National Kidney Allocation System and explicitly calls out the need for federal regulations for selection criteria to be evidence-based, minimum, objective, and measurable. These regulations explicitly apply to selecting patients from the national wait list in an effort to improve fairness and effectiveness. But in my mind, they should rationally apply to the entire evaluation and selection process. So to take an example, there's been multiple major trials in cardiology that have questioned the utility of routine cardiac revascularization, and that's prompted substantial debate among people in the transplant community and cardiology about whether cardiac catheterization for asymptomatic people prior to kidney transplant is valuable. Given this uncertainty about the best approach, Dr. Cheng at Stanford has showed that there's substantial differences in invasive versus non-invasive approaches to cardiac evaluation between programs, an example of a lot of heterogeneity. The evidence about whether behavioral patterns are associated with post-transplant outcomes is even more lacking. So, for example, non-adherence to immunosuppressants is a major concern for post-transplant outcomes, but unfortunately there's no great evidence that any particular pre-transplant characteristic or behavior can really predict that. And maybe worse than the lack of evidence is evidence that these selection criteria might be detrimental. So, for example, Dr. Layden at Tufts and her colleagues have developed a substantial literature on the requirement for social support and showed that this requirement can really have a differential impact on underserved groups and people at socioeconomic disadvantage. I think ultimately, to be more effective, the process needs to monitor and be able to continue to identify opportunities to improve. We need data collection and monitoring of the entire transplant process as a whole. I think it's notable on reflecting on this work in the VA that the VA actually has a relatively standardized and centralized process of evaluation. There's a list of evaluation steps that patients need to complete, and referrals are monitored internally and collected on the national scale. So for me, it makes it all the more notable that patients in our study, as well as their local providers, could be uncertain about what to expect from the transplant process. There's been calls from several thought leaders in the United States to work toward collecting more data on transplant referral. There are existing models of how this monitoring might be done. So, for example, Canada has a national registry that captures all referrals for transplant evaluation to transplant centers. But I think there's going to continue to be a question about what organizations or organization should perform this task and how to do that. I'll leave you with a call to action. I think now is the great time to work toward improving this process. The Advancing American Kidney Health Executive Order has really underlined community leadership's dedication to expanding access to treatment options, including transplant, and supporting patients' choice among multiple treatment options for end-stage kidney disease. And CMS, as many of us know, is also experimenting with new monetary incentives to support dialysis centers and providers in referring patients for evaluation. So I think now is really when we have the momentum. I'll end by just reviewing the objectives. First, we aim to review ethical considerations in selecting patients to receive a kidney transplant, and described the importance of supporting multiple ethical principles and what appears to be a focus mostly on how to support these principles in waitlist selection. We explored care processes in the early steps of the kidney transplant evaluation and noted an extensive evaluation process over which patients and local providers could sometimes have little control. And then we identified opportunities to improve the kidney transplant evaluation and selection process. We mentioned stakeholder engagement, refining our approach to the evaluation, and developing a system of longitudinal oversight. So with that, I'll close. I really appreciate the opportunity from the ESRD National Coordinating Center. I'm supported by my home division, the Division of Nephrology at University of Washington, and also the VA Health Services Research and Development, and some support from the National Institute for Diabetes and Digestive Kidney Diseases. And of course, this work is the result of the collaboration of multiple colleagues and co-authors, which I hugely appreciate. So with that, I'll close. Thank you.
Great. Well, thank you, Dr. Butler. That was a wonderful presentation, and appreciate that. Well, yeah, we switch back over to Matt. We do have some questions, so I'll go ahead and we do have a good 15 minutes left, so that's great. I will go ahead and start with some questions that came in. What websites would you recommend for patient information aids?
Oh, that's good. I should have a list. So the UNOS website does have some good visuals. And then there are other independent decision aids. I'm thinking of one from Rachel Patzer's group, I think called My Choice. Don't quote me on that. But if there's a way to disseminate, I can certainly collect those and get them back to the group.
Yeah, Dr. Butler, if you want to send them to me, then I can send that out to all the participants today. And I have their emails and through WebEx, so I'd be glad to share that with everybody in the next day or so when you get a chance.
Sure.
Okay, great. Okay, I'm going to move on. I am a social worker in a rural area. I feel pressure to have more patients referred and listed, but there are no resources to provide those things you identified as barriers, such as caregivers, transportation, and finances.
Right. That's difficult. When I say that I have as many questions as suggestions for this last part, I that's the kind of thing that I think will benefit from a lot more heads and a lot more people at the table. But to think in broad strokes, I think that this kind of issue needs to be approached at multiple levels. More interaction and engagement between you and the local team and the regional transplant centers might be a start. But actually, I mean, you as a person with this experience are probably in a great position to start to be able to contribute ideas to those kinds of questions.
Oh, great. Right. I have another question here. Is it still advantageous to have patients waitlisted at multiple transplant centers?
I think that the advantage there would be if a regional kidney that was going to go to a certain region came up more quickly in one region than another. There might be an opportunity to get a transplant sooner. That's my impression.
Okay, right. Okay, so let me see. A kind of a question here. We are a hospital-based community dialysis unit. If we were to have a patient who is also a VA patient, is it preferred to refer the patient to the VA system in addition to the other transplant centers?
That's also probably going to be a benefit from a discussion with the patient. And also the VA approach is in evolution. There's currently most recently the Choice Act allows patients, veterans, to be evaluated outside the VA and the VA to support it. So if there's financial considerations, going through the VA has some benefits there. But I would say one kind of caveat is a patient being worked up at multiple centers. There's not I think, a good system for addressing some redundancy in the kind of processes they'd have to go through. That's the kind of thing that I think coordination in the future and kind of more standardization might help address. But as it is, I wonder if that would be a bit of a barrier.
All right. Okay. Great. Thank you. I got another question here. What is being done to address implicit or explicit biases with practitioners?
Mm-hmm. Mm-hmm. Well, I can suspect that you are aware, and we're all becoming more aware of a huge literature and a need to address biases on, again, multiple levels, personal interactions at the organizational levels. But I would say there's a few aspects of the process that we could address to maybe account for these. And one of those would be coming up with criteria for kidney selection that are more standardized and that avoid some of the more subjective determinations of whether a patient is a kidney transplant candidate.
Okay, great. Thank you. Since the pandemic started last year and telemedicine has become a little more popular, do you feel like this has hindered or helped the transplant evaluation process?
I would be really curious to hear from some of the transplant professionals, but I have heard from some in our group that a good amount of the evaluation can be done by telemedicine, and many patients have really appreciated that, and especially patients in more rural areas for whom travel can be a barrier. So I do hope that telemedicine and transplant evaluation, as well as a lot of other parts of our healthcare system, can continue.
Exactly. I can see definitely where that would be, in this case, definitely will be helpful for those patients, or they just have transportation,
Right.
issues anyway that may not live rural. Okay, let's see. What would you say to a patient fears financial burden after transplant? Example being, I find many of my patients are fearful of losing SSDI and insurance.
That's also a difficult question. I think there's not an explicit reason that should happen, but of course, this process interacts with a lot of different parts of life. Their medical care is not segregated from the rest of their social considerations. So I think I probably have to know a little bit more about that particular patient's setting. But this is probably another spot for local social workers, local kidney care team members to take an active role in the transplant process to address some of these more personal considerations.
Great, thank you. Let's see, I got another question here. As a dialysis patient, should I consider accepting a high KDPI kidney? Yes, should I accept a high KDPI kidney?
That's a good question, and there's a lot of research looking into exactly what situations would best are those in which people would do better accepting a high KDPI kidney versus waiting a little bit longer for maybe a different kidney. And so this would benefit from a discussion with your transplant provider, but there's there's data coming out and kind of calculators about where exactly that kind of sweet point is, and it really depends on where you are on the wait list and how you're doing otherwise. But very important consideration.
And I think this is the second part to it. If you know, it says I've heard that the criteria for high KDI kidney is changing. Do you know what those changes are?
The definition of a high KDI?
Yeah.
I am not sure that I can answer that question. I'm not sure.
Okay, great. Thank you. I have another question though. That's our company has a dedicated transplant coordinator at each clinic to assure that each dialysis patient is referred to a transplant center. This RN follows and encourages process with each patient. I think it helps with better outcomes. But just a comment there. So something that they're doing.
That's wonderful, and I think I've also worked in our VA has a transplant coordinator locally at our kidney clinic, and just recently transitioned to another role, and the small gap of not having her has just reinforced how important that coordinating person is, and I totally agree. That's a great model for clinics that can support it.
Yeah, glad to hear that they're doing that. That's nice. Okay, is the financial barrier still there related to a successful transplanted patient needing to assume costs of the meds after 18 months when the ESRD Medicare status ends?
This is a very timely question. There's currently legislation, the Immunosuppression Act, to try to extend the coverage for immunosuppressants, and it seems a bit of a no-brainer. People who lose their coverage and aren't able to pay for and receive immunosuppressants, I think, is one of the most heartbreaking things that many of us see in clinic and in the hospital. And I do hope that kind of barrier is resolved soon.
Mm-hmm. Yeah, I know there was going, so that'll be interesting. Stay tuned. Okay, let's see. I've got another one here. Dietitians are a part of the care team and selection committee. Can you point me toward national compliance guidelines for nutrition status and transplantation candidacy?
Well, I think part of the problem, and again, if there's someone in the audience that can add information, that would be great. But in my mind, part of the problem is that there's not really standardized accepted guidelines for a lot of these criteria. There are clinical practice guidelines that offer some kind of structure to thinking about these. And I'd have to think about whether nutrition is specifically discussed in those. Yeah. So I'd have to refer back.
Okay. Great. A question here. Are we anywhere close to establishing a universal evaluation system to minimize subjective evaluation?
I don't think so. Like I say, I think that I personally have been interested in studying the VA process because I think it represents one of the few and most standardized processes that we have. The VA system does have a sort of checklist of evaluation steps that providers and patients have to go through before they refer. Things like cardiac evaluation, cancer screening in the right setting, and that sort of thing. So the fact that our study shows quite a bit of variation and uncertainty is telling. But I'm certainly on the same track that I think that would be valuable.
Mm-hmm. Great. Let's see. We got probably time for another one or two. Let's see. Is there a requirement to educating transplant providers regarding cultural competency and unconscious bias?
As far as I'm aware, there isn't. But again, I'd be interested in others' thoughts. And I know that this kind of training is more and more of interest to more and more recognized as important by our professional societies. So there's certainly a move to incorporate that kind of training and a lot of other ways of addressing implicit biases in our healthcare processes.
Okay, great. This one I think is a real quick one. When can someone be referred to a transplant? GFR 20%? Kind of a question mark.
That's my understanding of the rule of thumb. Yes.
Okay. I think we're good. We're coming right close to the top of the hour, so I want to keep on time. So, Matt, is there a next slide? I think just we're going to close up here. I just want to share with you a little bit of some resources that we have available at the NCC. We have the Kidney Transplant Hub. This contains resources to help patients consider transplant as a preferred treatment option. You can see the website down there. It's www.kidneytransplanthub.com. You can look at it, providers or patients. It's a really good, has a lot of good information. So we encourage you to visit that website. I think the next slide. We also have what we call the Transplant Trailblazers patient peer program. Again, this was connecting kidney transplant recipients with dialysis patients to support their journey. You can use the QR code now and scan it, or you can visit us at the ESRD NCC. There's our website down there. You click the transplant accordion and select Transplant Trailblazer program. Again, it has a lot of good information about how to get this started in your area as a way to help patients through dialysis patients on their journey and help them get connected with a patient who has been transplanted. Next slide. And just a reminder to everybody who has attended, if you do want CEUs, please keep your computers open. When we end this program, you should be directed to an evaluation. And if you can complete that, once you complete that and submit that, you will then be taken to our learning management system where you will be able to obtain CEUs. And CEUs are available for nurses, dietitians, and social workers. So again, I just want to thank Dr. Butler for taking time out of her day today for this wonderful presentation. A lot of good questions came in through the chat. Dr. Butler, I can see they were engaged. We had a good turnout. And thank you we got through, I think, all of them. So that's always good to have. And thank you again. And thank you, everybody, for attending today. We appreciate you being here. Take care. And we hope that you will join us on a future webinar. Thank you so much.